He didn't want my mom to drive, so he just drove. Oh, I think the directions now. He doesn't use that in his post. Yeah. He just kind of knows where to go. I'm not like plugging in.
Hello, everyone. Welcome to our Zoom meeting. Today we'll have different topics, and when you are ready, you can take it from here. Thank you, everyone.
Okay, our first topic is schizospectrum psychotic disorder will be presented by Dr. Rayyan. Are you with us, Dr. Rayyan?
Yes, I'm here, Dr. Ahd. I'm ready.
Okay, Dr. Rayyan, you can start.
Yes, just give me a second. I'm sharing my screen. I just want to make sure that it appears to you.
Yes, we can see your screen.
Thank you so much. So, Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, Eid Mubarak. I'm so glad to be here today. And I'm so glad to be a part of the presenting team for today, of course. My topic today is about psychosis in older adults, schizophrenia spectrum, and other psychotic disorders. Before starting, I want to highlight something. This topic is not we have a lot of things inside this topic, and because I have been working lately in the with geriatric patients, so I have seen many patients with the psychotic symptoms. So psychotic symptoms in elderly, I feel it's not an easy topic, or particularly the differential diagnosis. You need to be careful during your assessment, or the physical assessment, or the physician assessment that you're doing to the patient, because it's a very sensitive and very common and underdiagnosed topic, you know. So the psychosis in older adults, I'm gonna start. If you are all with me, I'm ready to start. So the objectives for this lecture is to define psychosis in geriatric patients and differentiate delirium, dementia, and schizophrenia, and recognize the late onset schizophrenia, to identify medical causes of psychosis in elderly patients, and understand principles of antipsychotic use in geriatrics. Let's move to the next. So what is psychosis, or why psychosis is important in geriatrics? Actually, it's really common and often under-recognized, and it's usually secondary to medical illness. What I'm trying to say is that in elderly people, you can find some psychotic symptoms, but before diagnosing anything, like, you know, in adults or the adult patients, you can diagnose the primary psychiatric condition, like schizophrenia in adults. But in elderly people, first of all, you should exclude other causes of psychosis rather than the primary psychotic symptoms or primary psychiatric diagnosis like schizophrenia. So first of all, we need to exclude other causes. I have mentioned already in the first slide that we need to differentiate between delirium and schizophrenia. So we have common causes of psychotic symptoms in elderly rather than the primary psychiatric conditions. So it's usually the psychosis in elderly people, it will be secondary to other conditions, not primary psychiatric illness. That does not mean schizophrenia is not present in elderly or geriatrics. It does present, but not common as the adult population. So the psychosis is common and often under-recognized and usually secondary to medical illness, and it's associated with falls, hospitalizations, caregiver burden, and mortality. And I have been with many geriatric patients, and I have seen that most of the time I visited my patients. So there is really a risk of falls and hospitalization, and of course caregiver burden. Some people will develop caregiver stress. After we are going forward in this lecture, I can mention that. Antipsychotics carry major risk in elderly patients, and that is really true. There is some complications that could appear from the use of the antipsychotics. So what is psychosis? Actually, we have categories for the psychosis, or we have the main categories of psychosis, which are hallucinations and delusions. The hallucinations are perception without external stimuli. And we have examples for that: the auditory hallucination, visual hallucination, tactile hallucination, and olfactory hallucination. We have also gustatory hallucination, like to taste something that is not existed, okay? So we have the hallucinations and the delusions, which are the fixed false beliefs despite evidence. And we have the paranoid delusions, grandiose delusions, and somatic delusions. So this is the main psychotic symptoms: the hallucinations and the delusions. So we should have an approach to psychosis in older adults. As I mentioned, psychosis in elderly people, you should think about the secondary causes all the time. Do not think it as like a primary psychiatric condition, like the schizophrenia that we know in adult people. You should exclude the other secondary causes. What are the secondary causes for the psychosis in elderly patients? We have the delirium. We have, sorry for that. We have delirium, we have dementia, we have a stroke, we have Parkinson's disease, we have medications, and of course, elderly people will have a lot of comorbidities, so they will receive many medications, and guess what? Some of the medications are associated with the psychotic symptoms, okay? So infection, metabolic disorders, and after excluding all of these conditions, the secondary conditions that could lead to psychotic symptoms in elderly, then we can consider the psychiatric conditions like depression, bipolar disorder, schizophrenia spectrum disorder. So before going to this, I want to say something. You know, we have been talking now about the psychotic symptoms. I just want to talk about the main conditions, or the main diagnosis for the psychotic symptoms. We have schizophrenia. I just want to mention something. We have the schizophrenia that all of you know it. Okay, so the schizophrenia can occur in adults, the classic schizophrenia, and it can occur in elderly people or geriatrics. So in geriatrics, we will call it late onset schizophrenia. Okay, so the adults, usually the typical or classic schizophrenia, you know, we have positive symptoms and we have negative symptoms. All of you know that the positive symptoms are the delusions, hallucinations, and of course the disorganized thoughts. And the negative symptoms contains the social withdrawal and apathy. So the symptoms for the classic adult schizophrenia. And you know, it usually appears in the late teens, late teens and 20s. So it usually appears early in the life. And the schizophrenia in adults, it will present with the positive and negative symptoms. And of course, they will be like a huge functional decline in patients or adult patients with schizophrenia, because early in the life, the patient will not be able to complete his medical school. He will not be able to complete his, universities. He cannot marry. He cannot do the normal thing that he should do. So there is a functional decline, and there is loss of personality. But in elderly people, usually the schizophrenia will appear late, like after 40s, after finishing the university, after finishing the school degree that he should do, after being married, after raising children. So the personality will be preserved and the function will be to some extent intact, but with the psychotic symptoms, okay? So what I'm trying to say here is that the psychotic spectrum disorder in elderly people, it's usually a symptom that needs systemic evaluation because it has a secondary cause. But in adults, it could be a primary cause or a primary condition like the classic schizophrenia in adults, okay? But in elderly people, we should exclude the other things like delirium, dementia, as I mentioned, medical causes like stroke and Parkinsonian disease. The medications are very important, okay? So let's move. This is delirium, vice versa dementia, vice versa schizophrenia. So why I need to talk about that? It's really, really very important because, you know, during my work, I have seen many patients with psychotic symptoms. Some of them will be completely normal before that, like they did not have any history of psychiatric illness or any mental issue or any mental disease, but they have a lot of other comorbidities, like elderly patient with diabetes, hypertension, hyperlipidemia, other things. But suddenly he started to develop loss of consciousness, impaired of attention suddenly. And after that, you can dig deep and find that the patient has something else, like a medical condition, like UTI, he was constipated, he had an infection, lung infection, pneumonia, anything. Then he suddenly started to develop the loss of consciousness and impaired of his attention. So the delirium is one of the commonest causes of psychotic symptoms in elderly people. So you should exclude it before anything else. It's one of the important secondary causes of psychotic symptoms in elderly. So the onset is very acute and the attention and consciousness will be impaired. The hallucinations are visual. Usually it will be visual. And of course, it's reversible because after treating the underlying medical condition, the patient will be stable. So regarding the hallucination, before continuing to the dementia and schizophrenia, I want to mention something. We talked about the hallucinations and about the delusions, right? I'm gonna make another color here. We said the hallucinations. What I want to say about the hallucination, you know, we had many subtypes of the hallucinations, but I want to say something. We have the commonest are the visual hallucinations and of course auditory hallucinations. The visual hallucination are associated with what? Associated with the delirium. Usually the delirium associated with visual hallucinations. Also, we have something else. You know the Lewy body dementia? The dementia that are associated with Parkinson's disease, it's also associated with visual hallucination. So in the hallucination, I want to just highlight this concept. It's very important. So Lewy body dementia and Parkinsonian disease and delirium, they are associated commonly with visual dementia, usually. The auditory dementia, it's associated, of course, you know, the adult schizophrenia or the classic type of schizophrenia in adults. The auditory hallucination is more common than the visual hallucination. So the auditory hallucination is associated with schizophrenia, the classic type, and of course, it could be associated with mood disorder. Okay, this is regarding the hallucinations. Regarding the other psychotic symptoms, which are the delusions, also we have subtypes of the delusions. But one of the commonest delusions that I have seen, even in the home care settings while visiting my geriatric patients every day, I have seen the suspicious and paranoid symptoms. You know, it's one of the delusions or psychotic symptoms that considered to be very common in elderly people. So the paranoid delusions, it's considered to be the commonest type in geriatrics, okay? And I can say something, it's also associated and common with some conditions. In elderly people, I have seen it with dementia, particularly the Alzheimer disease dementia, and also the paranoid delusion associated in adults with schizophrenia, the classic type of schizophrenia. So just I want to highlight that because in elderly people, the paranoid or suspicious delusions are very common, and I have seen it many times, okay? This is regarding the hallucinations and the delusions and the commonest subtypes that we can find it in elderly people. So we can go back to our slide, delirium, vice versa, dementia, and schizophrenia. You know, the delirium already is considered to be a very important topic, and you should exclude the delirium before any other primary psychiatric condition. We have the dementia. Of course, dementia, it will take a long time to develop. So there is a gradual onset, and the attention will be impaired later. So the patient could be conscious to some extent. And of course, he is conscious. The hallucinations could be there. And of course, it's irreversible, unfortunately. Regarding the schizophrenia, you know, if you want to diagnose schizophrenia in adults or late onset, but schizophrenia as general, if you want to diagnose it, you should have at least one of the positive symptoms and the negative symptoms for more than 6 months. More than 6 months to diagnose schizophrenia. So the onset will be chronic, and the attention is preserved, the consciousness is preserved, the hallucinations is there. Commonly the auditory, as I mentioned, the adult onset or the classic schizophrenia in adults, the commonest type of hallucinations is auditory, and it could be reversible, but it's a disease for life. You know, schizophrenia, the patients with schizophrenia should receive the antipsychotics for life. Let's go. So there is many causes of psychotic symptoms or psychosis in elderly. There is really many causes. First of all, we have the medical causes. As I mentioned, there is some infection that can lead to psychosis in elderly, and this will happen acute, and this could be diagnosed as delirium. Okay, there is some underlying medical conditions like stroke, Parkinson's disease. This could be a real cause of psychotic symptoms. Sometimes we will have like electrolyte disturbance. Sometimes we have metabolic disorders. All these should be excluded first as a cause of psychotic symptoms in elderly before looking for any primary psychiatric condition. We have neurological conditions, as I mentioned, stroke, you know, I said stroke and what? Parkinson's disease and other things. Medications, yes, there is a lot of medications that could increase the dopamine in the brain and can lead to psychotic symptoms. Other medication could work and increase other neurotransmitters rather than the dopamine to produce the symptoms of psychosis. And of course, at the end, you should think about the primary psychiatric conditions like schizophrenia in elderly people. It could occur, but we will put it at the bottom of the list. So we can move. So this is the causes of psychotic symptoms in elderly. And as you see here, the medical conditions, infection, electrolyte imbalance, hypoglycemia, stroke, and organ failure. We have neurological conditions, yes. As you said, we have dementia, Parkinson's disease, Lewy body dementia, which is a dementia associated with Parkinson symptoms. We have something called Parkinson's disease by its own, like the Parkinson's disease. There is a dementia with Parkinson's disease, and there is Lewy body dementia. There is a huge difference between dementia with Parkinson's disease or in Parkinson's disease and Lewy body dementia. Parkinson's disease will be developed first. In Parkinson's disease, we will have the motor symptoms, like the triad of the motor symptoms, rigidity, tremors, body dyskinesia, shoveling gait. All these things will appear earlier. So the patient with Parkinson's disease will present with the motor symptoms first, and then after that, with several months or several years, he will start to develop the dementia or the psychotic symptoms with dementia. Okay, but the Lewy body dementia, actually, the patient will start to have like the visual hallucinations, the cognitive dysfunction, the sleep, the rapid eye movement, sleep disorder, before the development of the motor symptoms or the Parkinsonian symptoms. So we have Parkinson's disease with dementia, and we have Lewy body dementia. The pathophysiology is different from each other, okay? So we have other medications that could lead to psychosis, steroids. One of the important medications that could lead to psychosis, opioids, dopamine agonist. Of course, you know dopamine agonist. One of the causes in the brain for the development of the psychotic symptoms is that we have something called what we call it, mesolimbic system, right? We have the mesolimbic system and mesocortical system. The mesolimbic system, we have a dopamine in this pathway. If we increase this dopamine in this pathway, this will lead to high level of dopamine in the brain, and this will lead to the symptoms of psychosis. So dopamine agonist is one of the causes of psychotic symptoms. And you can ask yourself, patients with Parkinsonian disease, they will receive dopamine agonist because you know that in Parkinson's disease, we have already a problem in the midbrain. In the brainstem, we have the midbrain and then bones and then medulla oblongata. So we have a problem in the substantia nigra that the main cause is the depletion of dopamine in the substantia nigra or in the midbrain. So people with Parkinsonian disease will receive dopamine agonists like levodopa, carbidopa. They will receive these medications to increase the dopamine in their brain. But unfortunately, in the other pathway, we have, this is called the nigrostriatal pathway. In the mesolimbic, you will increase the dopamine also. So in Parkinson's disease, the pathophysiology of the disease itself could lead to the development of psychotic symptoms like the hallucinations and the delusions. But guess what? The dopamine agonist or the medication that have been used for the Parkinsonian disease or Parkinson's disease, it could lead to the development of psychotic symptoms because it will increase the dopamine in the other pathway, which at the end or ultimately will lead to the development of these psychotic symptoms. Also, the polypharmacy, we said there is many medications that could be taken together, and it will increase the risk of the psychotic symptoms. And at the end, of course, the psychiatric or the primary psychiatric conditions like depression, bipolar disorder, and schizophrenia. Okay. So what I'm trying to say here is that we have something called schizophrenia-like psychosis of late life. So I mentioned that schizophrenia could be presented in adults or in young adults, late teens and 20s. This is the classic schizophrenia in adults. And schizophrenia also could be developed in elderly people or in geriatrics or in people more than 40 years old. It's not common, but it's found. We can say that it's found. So the characteristics of schizophrenia-like psychosis of late life, it's usually present after 40 years old, and it's more common in females. You know, the schizophrenia in adults, the classic one, male and female are equal, okay? The schizophrenia in adults, but in schizophrenia-like psychosis of late life, it's more common in females. They said that it was 1 to 5 or even 1 to 10. So it's very common in females, in elderly. I have read that about this concept. They said that because females will have a low level of estrogen after the menopause or after 40 years old, the estrogen was acting as a protective hormone for the symptoms of psychosis. And after the decline of this hormone, this will lead to the development of psychotic symptoms. So it's more common in females than males. And the paranoid delusions are common. Yes, that's true. Less thought disorder. I just want to say something very important. The schizophrenia, the adult subtype, if I want to put it here, just an important thing, the adult or the classic schizophrenia, okay, and the schizophrenia like psychosis of late life schizophrenia. Okay, regarding the thought disorder, you know that the positive symptoms of the schizophrenia itself, we have the delusions, hallucinations, and disorganized speech or disorganized thoughts. So in adults, schizophrenia or the classic schizophrenia, this is very, very common. So you can find like 50% of patients with adult schizophrenia, they will have thought disorder. They will have a problem to speak. Sometimes the speech will be not connected or lose association between the words. If someone asks them, they will reply in a different way. Maybe they will reply in a different sentences or concepts not related to the question itself. So in adults, schizophrenia schizophrenia, it's 50% or 50% of patients will have disorganized speech. But in late life schizophrenia, they have found that 5% only of the patients will have the disorganized speech or disorganized thoughts. So that's why in late life schizophrenia, as I mentioned before, the personality will be preserved, their function will be preserved to some extent. The disorganized speech is very low in their condition, but in adult schizophrenia, it will be different. The psychotic symptoms, the functional decline, the personality will be erased. There is a severe functional decline, and there is a loss of their identity. But in late life or in elderly people, the personality will be preserved usually, okay? So this is what I wanted to say. So we have the paranoid delusions, less thought disorder, but more in the adults or classic type of schizophrenia, and better preserved personality. That's what I'm talking about. In elderly, they will preserve their personality, but unfortunately in adults or the classic subtypes of schizophrenia, they will lose their identity or personality completely. So we have, regarding the psychosis or the psychotic symptoms, I just want to mention something. Just wait. So regarding the dementia-related psychosis, be with me. I want to use another color. Okay. So regarding the psychotic symptoms, we have psychotic symptoms in different conditions, okay? So we have the psychotic symptoms in different conditions. First of all, I want to talk about the delirium. So I will put it here, you know, number 1. Delirium, okay? And we have another thing, psychotic symptoms in delusional disorder. And we have a psychotic symptoms in mood disorder. And also we have a psychotic symptoms in dementia. You know, the psychotic symptoms, we talked about it already. We said the psychotic symptoms, we will have the visual, we will have the hallucinations, and we will have the delusions. So both of them could be found in the psychotic conditions. So I just want to put a point for each condition. Like the delirium, I have mentioned that earlier. In delirium, we will have a psychotic symptoms. Regarding the hallucination, which type of hallucination will be commonest with delirium? Visual hallucinations. So the hallucinations that could be commonest with delirium is the visual hallucinations, okay? And of course, we will have the impairment of attention and level of awareness. Regarding the delusional disorders, you know, you could have someone with isolated delusional disorder. He has nothing else. He has only delusional disorder. There is no mood disorder. There is no hallucinations. There is no cognitive dysfunction, only isolated delusional disorder. This could occur. Okay, so the delusional disorder or psychotic symptoms in delusional disorder, usually there is no hallucination, mood disorders, or even cognitive impairment. It's usually common in women and severe in men, and the commonest type of delusions is the paranoid delusions. You can find it common everywhere, the paranoid delusion. Regarding the mood disorder, the psychotic symptoms in mood disorder is easy. You know, you have depression, and you have mania, right? The bipolar type 1, we will have mania and depressive symptoms. So the depression itself, you can find some delusions. If you think about it, the delusions in depression will be self-blame and hopelessness. It's like a symptoms from the disease itself. So the psychotic symptoms will be self-blame and hopelessness. And in the mania, we will have the grandiose delusions, grandiosity. You know that. I know all of you knows that, okay? So this is what I wanted to talk about. And regarding the dementia, so the dementia is one of the commonest conditions in elderly. I have seen it many times in elderly people, and they will have some type of hallucinations. But I have seen elderly people with dementia that they could have auditory hallucination and visual hallucination, actually, both of them. So it's usually involve both hallucinations and delusions. It's a little bit less complex than the hallucinations or the psychotic symptoms that found in schizophrenia, okay, and mood disorder, but it's found. So we will have the hallucinations and the delusions. And regarding the delusions, the commonest delusion in dementia, also I mentioned it in one of the slides earlier, is the paranoid. Okay, so this is the dementia-related psychosis. I just mentioned that because I know I need to talk about the psychotic symptoms with delirium, with delusional disorder, with mood disorder, and with dementia. So the common delusions I'm talking about the dementia-related psychosis. The common delusions are theft, abandonment, infidelity, persecution, and hallucinations, especially visual hallucinations, but I have seen both actually in the reality. So I wanted to say something. I have one of my patients that I made a good bond with him, and he has been diagnosed with dementia. So he was good at first, and after a while, because I have been with him for a very long time, or several months, he was good at the beginning. He is 85 years old male, and he was good, but he started to develop the dementia, and he was living with his wife only, him and his wife. And after a while, he started to have these delusions. And because he has been already diagnosed with dementia earlier, after a while, he started to develop the psychotic symptoms. So he had the paranoid psychotic symptoms or paranoid delusions. So he started to accuse his wife that she took his money. Sometimes he is accusing the assistant in the home that they are trying to poison him. So he was good for a while when I contacted him, when I visited him many times before. Then late of the dementia, or after a while from the dementia, he started to develop the paranoid delusions. So this is something common in elderly people. I mean, with dementia, it could appear. Dementia with Lewy bodies. So dementia with Lewy bodies is one type of dementia that associated with a different pathophysiology from Parkinson disease. We have accumulation of something called alpha synuclein in the brain. This will lead to the development of visual hallucinations, fluctuating cognition, Parkinsonism, and rapid eye movement sleep disorder or sleep behavior disorder. The important point is that severe sensitivity to antipsychotics. You know, the idea here in Lewy body dementia that we have the antipsychotics that given to the psychotic symptoms will decrease the level of the dopamine, you know, the antipsychotic medications. If it was the first generation or second generation, at the end, it will deplete or it will decrease the level of dopamine in the brain. So patients with Lewy body dementia will have already a symptoms of Parkinsonism. That means the dopamine in the substantia nigra is low, or the nigrostriatal pathway in the brain contains less amount of dopamine. So when we start to give this patient antipsychotic medications for the psychotic symptoms that appeared with the dementia, this will lead to the exacerbation of the motor symptoms. So patients with Lewy body dementia, when they receive antipsychotics, they will start to develop severe motor or extrapyramidal side effects. They will start to have a very severe symptoms from the motor dysfunction. So those patients are very sensitive. They are considered to be very sensitive to the antipsychotics, and the treatment usually will be with a different antipsychotics. Like sometimes you will use another medication. The medication that have been used with this, the medication that has been used with these patients was called pimavanserin, okay, and other antipsychotics that could be less with the motor worsening, like quetiapine and clozapine, okay? So this is very important with dementia with Lewy body. So we have many medications that will induce the psychosis, as I mentioned, the steroids, opioids, levodopa and carbidopa. Levodopa is the medication that's used for the treatment of Parkinson's disease because we have low dopamine, but at the end, this will increase the dopamine in other pathway, the mesolimbic pathway, so the symptoms of psychosis will appear also. Anticholinergic, antivirals, and baclofen, all of these medications considered to be one of the causes of the psychotic symptoms in elderly population. We have a non-pharmacological management. Actually, the non-pharmacological management here, we're talking about the late onset schizophrenia spectrum. So the non-pharmacological management will be treat the underlying cause, or we are talking about the psychotic symptoms here as general, the spectrum as general. We should treat the underlying cause, reorientation, sleep optimization, correct vision and hearing impairment. You know, some people will have hearing impairment and vision impairment, and these will be one of the reasons to increase the delusions or the psychotic symptoms. For example, my same patient that I was visiting all the time, and he had a history of dementia, and then he developed the psychotic symptoms or the delusions or the paranoid delusions. Unfortunately, he has bilateral hearing impairment, severe bilateral hearing impairment, and he is not using hearing aids. He refused that. So he refused to use the hearing aids, and after a while, his paranoid symptoms started to increase. Why? Because he's not hearing very well. So sometimes he is interpreting people, a conversation or anything as something bad to him, or thinking about like someone trying to harm him. So without correction of the vision and hearing impairment, this will lead to increase the delusion symptoms or the psychotic symptoms in elderly. We need to reduce the environmental stress, and of course we need to educate the caregiver. For the same patient or my patient, because he was has a lot of complicated conditions before. For my patient, I said he is sitting with his wife. So unfortunately, his wife developed something called caregiver stress. She started to have some depressive symptoms, and she had anxiety. The chronic stress at the end lead to the depressive symptoms. So the patient, our geriatric consultant, started the sertraline for the patient. So the caregiver education is very important. You need to talk to the caregiver. You need to help her with different, of course, aspects, but the caregiver education for the patients with psychotic symptoms is very, very important. We should educate the caregiver, and we should try to help also due to the huge impact of the psychotic symptoms in elderly people on the caregivers or on their spouses. This will lead to anxiety and depressive symptoms at the end. So the caregiver education is very important. The antipsychotics in elderly. Usually, antipsychotics have been used in elderly for many conditions, like for all the spectrum of psychotic disorder, it could be used. But unfortunately, there is many side effects of antipsychotics in elderly. It can lead to falls. You know, the antipsychotic could be associated with sedation, and this will lead to, and some antipsychotics also work as anticholinergic drugs that could lead to change of the cognitive function of the elderly patients. So this will lead to other consequences like falls, also the sedation. At the end, we have another side effects like orthostatic hypotension, extrapyramidal symptoms, increased mortality in dementia, and all these side effects. So if you want to use antipsychotics in elderly, you should be very, very careful, and you should use it with caution. And there is a concept about the medicine in geriatrics: start low and go slow. You should start with the lowest dose, and then you will titrate up very slowly based on the tolerance of the patient to the medication. And guess what? The same patient, or my patient, he had the dementia, as I mentioned, and he started to develop the psychotic symptoms, and the psychotic symptoms was very, very difficult, and was very difficult because of the patient himself and because of the caregiver. So the patient used, or he started on antipsychotics, a low dose of antipsychotics. So the geriatrician put him on many psychotic medication. He was taking the dementia medication first, you know, the memantine, rivastigmine. He was taking these medications, and then risperidone has been added to the patient, and after that, it has been changed to another medication by the consultant himself, to olanzapine. I know that there is a lot of medication side effect, but one of the medication side effects that's really very serious is the sedation. The patient was walking, he was walking normally. He was complaining of unstable gait, but he was moving in a good way, okay? And he refused to use sticks. But unfortunately, after taking these medications for several weeks, after that, he fell down and he broke his femur and he underwent a total hip replacement. Unfortunately, because of the fall here, it's considered to be multifactorial, not only the medications, but he has the dementia. He has gait instability, and he refused to take any physiotherapy. So there is a multifactorial causes for the fall, but unfortunately, one of the causes of the fall itself was the antipsychotic medication that he was taking. So if you want to use antipsychotic medications in elderly, you should be very careful. So we have the common antipsychotic medication. We have the quetiapine, risperidone, olanzapine, and haloperidol and clozapine. So the quetiapine, it has the least side effects of the extrapyramidal. So risperidone effective, but it has extrapyramidal side effects. The olanzapine, it has the metabolic syndrome. It will lead to weight gain and other side effects regarding the metabolic syndrome and hyperglycemia. Haloperidol is considered to be first generation antipsychotics. It has a high extrapyramidal side effect, and clozapine also, one of the antipsychotics that needs to monitor the patient that receiving this drug. And I mentioned that the clozapine was one of the medications that could be used in the treatment of Lewy body dementia. So I just tried to, you know, to make it very short as possible as I can, and to mention the most important things about the psychotic disorders in elderly people. I guess this is the end. We have 3 cases that we will go through it, and you can help me to answer the questions if you want. So this is a clinical case. I will try just to find the keywords. We have 82 years old man who resides in a nursing home. Just wait. Because of Alzheimer's disease, already he has been diagnosed with Alzheimer. Dementia is disruptive during meals because he accuses staff and residents of poisoning his food. So he has paranoid delusion, right? He does not eat food from the nursing home, but will eat food brought in by family members. He trusts his family, but he does not trust others. Other residents do not want to eat near him because of his accusations. Family members report that he always has had suspicious personality traits that before that, but his paranoia has become more severe over the last few years. Since moving into the nursing home, he has lost 4 over the last 2 months because of his refusal to eat the nursing home food. He's not eating the food because he is suspicious of having something like they will poison him or something like this. There are no acute changes in his behavior or mental status. Examination and laboratory studies are unremarkable. Which of the following the most appropriate statement regarding the use of antipsychotics in this patient? So this patient has a delusions, a psychotic symptoms, which is the delusions, and it's a paranoid delusions in Alzheimer's disease. I already mentioned that in one of the slides. And the patient should start low-dose antipsychotics to control his symptoms. So the second generation antipsychotics double mortality compared with placebo, or citalopram is antidepressant. It will not be the right answer, of course. Second generation antipsychotics are associated with greater mortality than first generation antipsychotics. This is not true because the first generation antipsychotics is more, it has more side effects and side effect consequences in comparison with the second generation. So this will not be true, and this will not be true because citalopram is antidepressants and we are talking about the antipsychotics. So we have his symptoms justify cautious use of a second generation antipsychotics. I guess this could be the right answer because he has severe psychotic symptoms that impaired his daily activities or impaired his daily function. So we need to control his symptoms with low-dose antipsychotics. So the most correct answer here will be D. His symptoms justify cautious use of a second-generation antipsychotics. We can move to the next case. A 70 years old retired nursing supervisor comes to establish care because her primary care physician recently retired. She reported that her neighbors have damaged the stairs leading to her house to try to force her to move. So let's put here damage the stairs. She presents photographs of the stairs to support her concerns, but the stairs appear normal. So we have some sort of psychotic symptoms, which is delusions also. She also believes that her daughter damaged the staircase inside the house, and she asked her daughter to move out. She continues to function independently and remains active socially and in church activities. This is very important because I have mentioned before in one of the slides that the psychotic symptoms, we could have something called isolated delusional disorder. There is something called isolated delusional disorder. This patient will have delusions without any hallucinations, without any mood disorder, without any cognitive impairment, and they will be functioning very normally in their life. So this is called isolated delusional disorder. Someone with fixed false belief, either to be hallucination or delusion, but with no, they should have fixed false beliefs like delusions without hallucinations, without cognitive impairment, without mood disorder, with normal function in their life. So this is called isolated delusional disorder. And this, I guess this is one of the conditions in this case. She continues to function independently and remains active socially and in church activities. She manages finance and household responsibilities without difficulty. So the baseline function is normal for her. Examination reveals a well-groomed woman with normal speech and cognition. Laboratory studies are normal. Which of the following the most likely diagnosis? This is most likely isolated delusional disorder because she has nothing else rather than the paranoid delusion. Everything else is normal. The last case that we will discuss is a 67-year-old retired lawyer presents with several months of worsening insomnia, irritability, agitation, and suspiciousness, okay? So he remains highly active in volunteer legal activities and church work. Family members report emotional liability and progressive behavioral changes. He develops a fixed belief that caregivers employed for his court-appointed words plan to release fabricated, inappropriate photographs of him publicly. يبقى عندنا برضو delusion. We have a delusion of paranoid, which would damage his reputation within his religious community. He initially receives treatment for major depressive disorder with psychotic features, using antidepressants and a low-dose antipsychotic, but symptoms worsen after treatment initiation. What I want to mention in this patient, he is 76. He has symptoms like insomnia, irritability, agitation, suspiciousness. He has already a delusion of paranoid also, you know. He has behavioral changes. He has emotional liability. And he has been diagnosed, he initially received treatment for major depressive disorder with psychotic features, using antidepressant with a low antipsychotic, but unfortunately his symptoms worsen after treatment. Usually the depressed people will not have the the severe irritability and agitation, okay? And I have mentioned that the paranoid delusions or the grandiose delusions, they are different from each other, but those delusions associated with mania. In depression, we will have hopelessness or self-blame delusions, but this delusion here will not be associated with depression. It's not a psychotic symptom of depression. Plus, we have insomnia, irritability, agitation, and suspiciousness, and the emotional liability. This could be one of the presentation of the manic disorder. He could have manic disorder. This patient usually will have bipolar one disorder, which is manic episode, and this will be evidenced by the use of antidepressants. If we used antidepressants, we will increase the serotonin level in the brain, and this will increase the symptoms or exacerbate the manic episode. So patients with mania should not receive antidepressants. They should receive mood stabilizer. So either to receive like sodium valproate, lamotrigine, those quetiapine, those mood stabilizers. But when you are giving antidepressant, pure antidepressant to a patient with a manic episode, this will exacerbate the symptoms because already they have a high level of serotonin and dopamine. And when you are giving antidepressants, this is very dangerous in people with manic episode because it will exacerbate the symptoms. So which of the following is the most likely diagnosis? This is not delusional disorder because it affects his functional life. It's not late onset schizophrenia. Because we have mood symptoms. This is not major neurocognitive disorder with behavior disturbance. This is bipolar 1 disorder manic episode because the patient received antidepressant and his symptoms started to worsen. That means the antidepressant worsened his condition. So the most likely answer here is bipolar 1 disorder manic episode. So this is what I wanted to say. Yes, this is the answers. And we have key take-home messages that the new onset psychosis in older adults is delirium until proven otherwise. Always exclude dementia, stroke, medications, infection, and metabolic causes first. Visual hallucinations strongly suggest delirium or Lewy body dementia. I have mentioned that, when I wrote the hallucinations like visual, it could be delirium or Lewy body dementia or Parkinson's disease. I have mentioned that. And late onset schizophrenia is uncommon, but clinically important. Antipsychotics should be used cautiously in elderly patients. Start slow and go slow is the golden rule in geriatric psychopharmacology. And non-pharmacologic management should always be attempted first. So thank you so much, everyone. If you have any question, any comment, anything, feel free to participate.
Thank you so much, Dr. Ryan. This is excellent, wonderful presentation. Any questions?
If there is any question, anything?
So it's a very interesting topic and it's very common. So one of the things that you think about if we teach in geriatric medicine is the first cost for anything in geriatric is medication. So if you go on with nothing out of this lecture or this presentation, is you think about the history and when you have any patients elderly with any symptoms, look at the medication effects. The last thing you want to do is to start patient on the person that also in this case get some symptoms you want to help them, but you don't want to cause them harm. So there's for all rule is no harm. So when you take history from the assess the patient, the first thing you do is look at the medications. And most of the time it will explain things, especially if it's a new medication. Otherwise, the doctor clear. Thank you for that person. The business. Don't explain things out. Thank you so much.
Thank you, Dr. Rayyan, for the informative presentation and Dr. Nader for the addition. It was a useful reminder of the difference between psychosis in elderly and other age group and how to differentiate psychosis symptom, especially with delirium being a common presentation in this age group. We will now, if there is no any other addition or questions, we will now move to our next topic, in which Dr. Mylene would tell us about academic writing and how it is different. Are you ready, Dr. Mylene?
Yes, I am Dr. Ahad.
Okay.
Okay. Okay, so hello everyone. My name is Mylene, and I would first like to start off by thanking Dr. Nadir for this opportunity to be able to collaborate remotely and get involved in meaningful projects. Just a minute to share my screen. Um, mhm. Can everyone see my screen and can everyone hear me?
Yes, we can.
Okay, perfect. So today I'll be presenting on academic writing. I'm sure most of us here have at some point in a medical career been involved in medical research in one way or the other. So this is not new to us. It's just going to serve as a quick refresher on what academic writing entails. So yeah, let's start. By the end of my presentation, we should all be able to understand the concepts of academic writing, identify the basic structure and features of writing, academic writing, recognize different writing designs, understand the steps involved in a literature review, explore common databases used for literature searches, identify common mistakes in writing and how to avoid them, and apply practical strategies for improving academic writing skills. So first off, what is academic writing? It is a formal systemic mode of expression designed to communicate research, analyze theories, and defend claims. A good writing should have the following characteristics. It should be evidence-centric, that is, every claim must be grounded in empirical data or verified sources. It should have a rigorous logic. That is, it should flow sequentially with clear transitions. It should be structured in style. It should strictly conform to specific generic guidelines. These are just some major writing typologies. We have primary research, secondary studies, and observational briefs. For primary research, it involves first-hand empiric accounts written by original investigators who designed and conducted the experiment or survey. For secondary studies, it involves literature reviews and theoretical critics that synthesize, analyze, and aggregate existing published primary materials, and then observational briefs, clinical case studies, field descriptions, and policy briefs. It focuses on unique situational anomalies or niche phenomena. These are just major typologies researchers use depending on what they are analyzing, on what their research question is going to be. The structure of academic writing, there is a very common template called the IMRA template, which is basically from top to bottom, there is a title, author, abstract, and keywords. This is a descriptive information. It lets the reader search for an article. We have the introduction. It tells us the context of the project. It answers the question, why? Methods. What did the authors do to answer this question? How? The results. What was the answer to the question? What was it? Discussion/conclusion. What is the significance of this project? And then the references. Materials the author cited when writing this paper. So now we're going to go into the details of each section. I want to start by emphasizing that research is not just about what you say, it's about how you say it. So the tenses are very important to make the flow of your research formal. So abstract dynamics, it's a miniature portal to your entire paper. It demands rapid, structured narrative shifts. For the background context, it's formulated in the present tense for existing scientific status. Procedure and results of your abstract. It is expressed in the simple past tense. For example, you can say we observed so and so in your research. Closing impact, it's concluded in the present tense to show theoretical value. And then the introduction blueprint. The introduction is a funnel moving from the global concerns to your specific localized gap. The universal truths are standardized concepts. It utilizes the simple present tense. The historical literature, that is citations of previous studies, it relies on the past tense. Unresolved issues, general continuous literature trends use the present perfect tense. For the methods and results, for the methods, it's written to serve as a recipe for clinical or replication by other global researchers. Completed actions employs the simple past tense. For example, you can say tissue samples were centrifuged, blah blah blah, or something else in this structure. Passive structure frequently utilizes the past passive to ensure focus remains on the action rather than the actor. This is very important. You should always focus on what you did rather than who did what. Result reporting. A code completely uneditorialized objective report of your observations and empirical measurements. Observed actions, it's stated strictly in the simple past tense. For example, the cohort exhibited no variance. Active visuals, direct pointers to figures or tables, it switches to the simple present. For example, saying figure 4 outlines so and so. For discussions and conclusion, for the discussion complexity, the discussion is a stylistically complex, constant contrasting your findings with existing publications. Recapping your results, recount specific outcomes in the simple past. When you're recapping results, it utilizes the simple past tense. Theoretical context, it argues broader implications in the simple present tense. For example, this indicates prior literature refer to established models using the simple present. For example, this a model matches Lee, so and so. It's very important to respect these tenses in each section of your abstract because that's how it flows thematically. For the final conclusion, it represents the ultimate distillation of your paper, stepping back for an expansive global view. The global takeaway formulated in the simple print to define lasting scientific value. Future trajectories, it is using in the future tense or models to direct ongoing research. This slide shows a few writing designs. Say you're going to you decide to do a research on something. Once you have your question, you can decide on what style of writing you'd want to proceed with. So we have case reports. Case report, it's a highly detailed clinical description of a single patient or a small group of patients. It highlights a rare symptom, a unique pathology, or a new therapeutic outcome. The pro style here is simple past. Retrospective studies. Investigations analyzing historical, pre-existing administrative databases or patients' registries to map out specific exposure to outcome odds ratios. It also utilizes the past passive. It adjusts for bias. We also have systematic reviews. These are high-tier secondary research that systematically searches, critically appraises, and synthetically integrates all available primary clinical studies on a query. It uses the PRISMA guidelines, methodological present. Other writing designs include randomized controlled trials and meta-analysis. Randomized controlled trials is the pinnacle of primary research. It prospectively assigns human cohorts to experimental or control parts to eliminate confounding bias. Meta-analysis is a quantitative secondary design. It statistically measures the numerical outcome of multiple separate randomized control trials to calculate a single high-powered net effect size. So these are a few common writing designs you may want to choose when doing your research. So here we have literature review and steps to conducting one. I just want to emphasize here that literature review is very important. In fact, it's one of the first things you do before even starting to write your paper. What is it? It's a summarized and organized overview of existing research, studies, and information on a specific topic. It analyzes, compares, and evaluates what other authors or researchers have written to identify key findings, gaps, and trends related to the subject. Step to conduct a literature review involves define your question. Before you even start the research, you need to know what you're going to be analyzing. So you need to have your research question. You search the databases systematically, and then you screen and select relevant studies. After that, you critically appraise the evidence. This is very important. It involves assessing study validity, you evaluate the methodology, you identify bias and limitations, and determine relevance to your research question. And then finally, you synthesize your findings. These are common databases for literature searches. For example, for meta-analysis and systematic reviews, you may want to search databases like Cochrane, database of abstracts of reviews for effectiveness, that is the Campbell Collaboration Library of Systematic Reviews. For cohort studies, case control studies, case report, case series, you want to search databases like Medline, PubMed, Scopus, PsycInfo, and so on. For background information or expert opinion, you can go through textbooks, Access Medicine, Clinical Key. These are just a few databases separated according to the exact type of research you're performing. Moving on. Common mistakes in academic writing: poor structure, ideas that are not organized clearly. It makes the paper difficult to follow. A strong introduction, body, and conclusion, it improves readability. Lack of critical analysis. Simply describing information without evaluating and discussing the significance weakens the academic argument. Inadequate referencing. Missing or incorrect citations, it reduces the credibility of your paper and it may lead to plagiarism issues. Overly complex language. Using complicated words unnecessarily can confuse your readers. Clarity is more effective than sounding advanced. Plagiarism. Copying ideas or text without proper acknowledgement. It is unethical and it can result in academic penalties. Some tips for a successful academic writing include: plan before writing. Like anything in life, you need to have a plan. Create an outline to organize your arguments and maintain a logical flow. Read widely. Reviewing academic sources, it improves knowledge, vocabulary, and understanding the scholarly style. Use reference management tools. Tools like Zotero or Mendeley help organize citations accurately. Edit and proofread carefully. Revising grammar, clarity, and structure strengthens the overall quality of your work. Seek peer feedback, very important. Feedback from others can identify your weaknesses that you otherwise wouldn't be able to notice yourself, and it also provides a new perspective for improvement. So some final insights about my presentation for today. I know it was a quick one, but like I said, it was just a refresher for what we all already know. So impactful scientific contribution relies not on complex language, but on absolute structural transparency and flawless grammar. Academic writing is essential in medicine. Strong structure provides clarity. Referencing supports credibility, and actual review strengthens your research. By pairing logical manuscript anatomy with standardized verb tenses, you allow your data to communicate effortlessly with the scientific community. Thank you. This is all about my presentation. If you have any questions or any insights, happy to take any of them.
Thank you so much, Dr. Mylene. This is also excellent presentation. Any questions or any comments? Please
Thank you, Dr. Mylene. It was a great presentation that helped us to understand the concept of academic writing and how to apply it practically in our project. So if there's no other addition or other questions, we can move to our final topic for today, in which I will speak with you about a website which is called Simpletivity. Let me just share my screen. So, can you see my screen now?
Yeah, we can see it.
Okay, that's great. So, today I will talk to you about Simpletivity, which is a website, not a tool. It's a website created to help you by a productivity coach and educator. His name is Scott Friesen. Basically, it's an educational platform. He shared his idea about organization, time management. This is the creator of it, Scott Friesen. He has videos and tools. He also has a YouTube channel, which he shared the same videos in it. This is his YouTube channel. You can find multiple playlists in here. He explain how to use those tools, how to manage them, and the use of digital tools. It's especially useful for professional students, manager, or business team who want to organize their work better. He does not specifically give you a new tool, rather he tell you or explain how to use your usual tools in a new way. It also contains articles, courses, and coaching services, tutorial about the common productivity software, such as Google Workspace, Microsoft Office, Task Manager, note-taking application, and project managing tool. They have like a simplifying presentation for beginners. This is it. So he talked about how to simplify rather than use multiple tasks. That instead of constantly looking for new tools, people should simplify their workflow and make better use of the tool they already have. His core idea is organizing work into 3 categories, or what he called the productivity trinity. It's the idea that all you need is one good calendar. He said that a calendar is very important to know what you have to do, what you already done, and so on. A note app in which you organize your ideas, and whether it's an app or maybe you can use a pen and a paper, whatever you can use, and a to-do list. And he also say that the last two, the note app and the to-do list or the task list, shouldn't be the same, because sometimes a lot of people use them as the same thing. When you are writing note, not every note you write should be a task, because this will overwhelm your brain about thinking about, oh, I have all these notes, so I have all these tasks to do. You should have your notebook and then summarize those notes into a specific task, and then you don't put many tasks in one day. What else? So he have these tools. You can talk to him directly. You can send him. He asks 4 questions that will help you find the best next step, task, project, tool, and app, and then you provide them with your emails, and they will give you like a system to work on your project. So he say here, what should I work on next? The single more important shift you can make. When this place is clear, something powerful happened. You stop checking email to see what's urgent. So you don't jump from one app to another. One tool tomorrow morning, which tool would you trust to guide your day? Because we use many tools and many apps, But if we think about it, maybe 1 to 3 are the most important in our work. He have this exercise. Step 1, list every tool you opened yesterday, and you try to remember all the tools you use for your work. Step 2, circle the tools where you made real work decision. Step 3, underline the tools you open just in case, the tools that you don't really use every day, but you have them, you think they are useful, but you don't really use them. Even if people say that they are very important, they are very useful, if you don't use them, they are not important for you. Step 4, pick one underlined tool, one that you said you open them just in case, and try removing it this week. And you do the step every week, and then you will find yourself having only the important apps. So this is a good start that you can try to simplify your tools and your workflow. So basically, this is the app, and you will find it really helpful. I watched many of his videos. You can try to, he have tips and trick about Zoom, about Gmail, about calendar, how to simplify PowerPoint, time saving, and all of this. So you can check his website. It's really useful and helpful, and he know what he's doing. And yeah, that's basically it. That's what I have for today. I hope you find it useful and you know more about this website.
Thank you also, Dr. Ash, for also excellent presentation. I think it's a good tool or good website where you can find some way to help yourself.
Thank you, Dr. Nader. And also, I would like to thank our amazing speakers again and the audience for an engaging session. And as always, thank you, Dr. Nader, for providing this community and this opportunity each week where we can learn and share knowledge among each other. I hope you found today's presentation valuable.
Yeah, we're just having a great day.
Thank you so much. Yeah.
She needs some groceries. Oh, yeah.
Presentation great. So, Dr. Seth, please go ahead.
Assalamu alaikum, Dr. Nader. Actually, I'm a new member of this community, just joined maybe 2 weeks now, and I've already learned a lot. So I really thank you for this opportunity that you're providing us here with. I just had one question. It's probably not related to exact the topic of the discussion today, but I thought maybe if you would have an idea because you're very much engaged in this IMG community, is it possible to ask it right now, or do you prefer another
Yes,
means?
go ahead. No, go ahead, please.
So I have a friend on behalf of whom I ask. He is from one of the countries that's restricted at the moment to join the match program. He's from Syria, and he would like to know if he's already in the US. He came on the B1 visa, and now he has a postdoc offer for which he would have to get the sponsorship for the J1 visa. Now, the question is, do you think it's something that he should go ahead and apply? Because if he does get denied, considering he's making a status change, it might be a red flag for him to sort of get blacklisted from applying again in the residency program.
So I'm not quite sure with the process for the drawing, but I know the, for example, the Sudanese Student Association, I was working to get some of the list banned, at least the physician from these countries can be accepted as a second role, and to get them either in or let them in the system so they can benefit the population. But I think the best thing for him to do is to contact a lawyer to see what the best back there what the next step for him. I'm sorry, I don't want to run now.
Have you seen any person have success with this in your experience?
You mean with this recent changes or before?
Yeah, from someone from a banned country who had a B1 or similar visa and they ended up converting to a J1 sponsorship.
Yeah, I have it. But again, my connections, I don't have a lot of experience of people to tell you if there is one. So I have limited exposure in this area.
Sure, thank you. Thanks a lot.
You're welcome. I wish you a good life. If you have this. If there is
Inshallah.
anything to update us, yeah. Update us. Thank you.
Okay.
Any other questions for all the presenters from here or any other updates? I know some of you may be interested in the Cleveland clinic and the journalists and work with youth with youth force. So if you are interested, please let me know. And it's going to cost $100 to register for the course. And the course will be available for you guys for 1 year. So you can watch the recording during this next year. Yeah. Anything else you want to share in questions, ideas, comments?
Hello.
Hello,
Am I heard?
Please, yes. Go ahead.
Hello, Eid Mubarak to everyone. To those celebrating. I just wanted to say that our abstract for fibromyalgia, it got accepted in the Noisy Plastic conference in the University of Michigan. Although we have a problem, they are not accepting virtual presentations. So we would need someone to present on behalf of us, on behalf of our team. So if there could be anyone in the group who is available to present on the 4th of August, it would be a full day occasion. So yeah, if anyone would be free.
I know there are some fellows who are in the Michigan area, so maybe we can reach out to them, see who will be available, and they will present that we will for them for you guys.
Okay, thank you so much, Dr. Nader. Okay, in regards, I wanted to show the update on app development. So I
Yes.
have been like just like almost like it's just a JavaScript as of now. So because I'm going to show you the final product like later on. I'm not quite satisfied with it, and yeah, wait, let me just share the screen.
Yeah.
Okay, everyone see my screen? Yes. Right,
Yes.
so we can start. Is it how I put it? Oh, yeah, here. So initially, I had like I had improved like Dr. Nader's initial work on this. I added like some stuff such as like the trends, allowing the patients like to see like a general trend on on how they're doing. So they just have to like log in the symptoms and see what's it. There was like I noticed that in the apps, in the past apps, there was like it's almost like a slideshow of how they were presenting, like, oh, how much is your pain? And it would like almost slideshow, and it was so slow. So like if I was having a fibro attack, I would not appreciate like how slow things were. So I decided like, why don't we just make it in one page to just remove the resistance of having to wait 3 seconds or so just to answer one question, in which they can just slide whenever they're having like an attack. So it's just something as easy as well as like in regards to their mood as well, how they were feeling, so we can just in general track it. There's also like and I also put like a symptom mapping in which they can just collect. So the level of how dark the how dark the color of pink is refers to how severe the symptom is. So it's not working as well because it's just an HTML file. But yeah, so it allows you to show. So less resistance. And here you have the triggers already like written for them. So that's going to be quite easy rather than actually having to write it down. I also like did transcribe in which like they're allowed to just tell the phone their symptoms and it would write it down. This was a little bit buggy on the phone, so I can't show you here because it's just so I mentioned like it's just an HTML file. And as well as you have the history here in which like they can log it, you can easily log it, it automatically logs. Here in the dashboard, this is the spoon theory by a doctor in which like they said it's a theory in which like people with chronic illnesses have way less capacity to like spend their days. So it's almost like they're in borrowed time. So before the day even starts for them, like they should already like see. It's almost like they should have like a power plant, not like someone who's normal and doesn't have like an illness and like is living their daily life like normally and is able to exercise. So this takes a lot from people with chronic illnesses. So you have this which like they can just write they can just click on like whatever, charge them up like what they did by the day that can be as a recharger and versus like something that can drain them. So so it'll automatically add into the count of the spoons here. And then they can also write down what was something that drained them so that they could easily track that as well. This is just a beta experience just yet. I'm open for suggestions and if anyone is also has like a bit of HTML because like I was asking if anyone knows like HTML or a bit of JavaScript coding because as you know like AI, although it's able to code for you, when you plug it on an AI application, it's automatically going to change like the look of an application. So it's not that perfect yet in coding. So you would need to have a little bit of coding experience in order to actually remain with an application and then just continue with that. So and then this is the initial app. But then I changed my mind, so I'm going to show you guys. So it also has like the Flare in which like you can log in the Flare and your cycle as well, in which it automatically reads it out. But wait, so here it automatically like tells you which time, where are you in your cycle, so that you can automatically like associate it. And here you can when you finish like all of that, when you finish logging it in, you can automatically copy it, and it will appear on like on a you can just it'll automatically appear on your email. So here is like a report that is like actually already automated by AI. Um, Still not perfect, as I said, like we still need to add a bit more coding. This was not this was a pain to just sync it with the phone. To add reminders as well was also like a headache on my behalf. So it still needs work. And this one I plan to remove it. This was an AI coach. It was actually a bit hard to include AI on that thing because then I would need to pay an actual AI here. So in which like here I added like a Gemini API key, which is almost like a secret key that would allow the clients who are using this application or the patients per se to use the app on an actual like artificial intelligence. So here you have like in which like they can just fast. But then I thought that would do them a disservice because then there's Gemini that they could just open and it's ready and they could use it on full capacity. And then so I then changed my idea. I don't know. So here this is a JavaScript. So here I have it's not opening. Probably opened it somewhere. Um, Wait, let me just cancel my screen share and just try to open it because I'm able to open it right now. Can people still hear me? Hello?
Yeah, we can hear you.
Yes.
Yes, okay. Hold up.
So I'm going to just elaborate while you are getting that screen up. So one of the things that about this app is
Yes.
the theory of one of the doctors on suggested that I'm just again I'm elaborating on the idea that patients with
Yes.
fibromyalgia or some of these conditions when they start their day, usually it's a hustle to complete the day because they will get fatigued with minor activities. And by midday, end of the day, they will be exhausted. So the idea is that they can get some activities to increase their abilities to combat this negative feeling of fatigue and exhaustion. And some of these will be added as a plus. It's like when you charge your phone or put a gas in your car, you want to fill that car, the tank or the phone to 100%. And in the morning, so that you can at least enjoy your day driving or using your phone. The same with this condition, for example, fibromyalgia. They need to charge or they want to do some activities or at least some things that put their energy level at 100. And then they plan their day so they can use this in such activities that will exhaust them, but in their favor. Like they want to go to the market, they want to play with their kids, they want to do so. They will see how much exhaustion each one of these activities will cost them, something like that. Am I on the right track?
Yes, you are.
Okay.
Absolutely. Exactly. Exactly. This is exactly what it is. So yeah, I actually changed the app a bit to make it like as you can see, like the color was super white, and so like I decided to also
Can you
change it
screen?
into
Can you share the screen?
I'm unable to open the actual code right now. I don't know why. My computer's like refusing to open it. But hopefully on the next session, I'll be able to open that one and show that one as well, so like people can differentiate on like what is going on. And I would like ideas as well, and in general, like just criticisms, so we can improve it together. And yeah, that's about that. Hopefully, I can show you guys that soon. Unfortunately, it's not opening. I'll show you as an application on the phone so that you guys can differentiate how it looks like.
The conclusion, I share the chat. I think.
Yes. Okay.
Or not? Yeah. So basically, you can test the code if you have the code.
All right. Okay.
Do you have as HTML or JavaScript or the code itself?
I think this needs a code, apparently, a token.
So do you have it like when you create it? Do you have it as a HTML code? for you or
It's
JavaScript
a
for
JavaScript.
you? Yeah. So I shared another link.
Yes.
It is called. Open the second link, and you can paste your code if you have the code
Yeah, I do
on the
have
left
the
side.
code. So it's showing me, I don't know, for some reason it did not. So it did not run. I guess it needs like a token of some sort.
Ah,
It tried to run. You know why it did not work on my commands? Hopefully I can share it
can you
like
share the
this.
screen? Can you share the screen again and go on top of it? Let me see if it figures it out.
All right. Here it is. I don't know what happened.
So go on the left box on all the top, all the way top, all the way to the top. Yeah, all the way, all the way.
Okay.
So all the these are just comments. And go down a little bit. I think the HTML starts somewhere down. Is so this is just the JavaScript only.
Yes, this is a JavaScript.
Okay, yeah. So you need to maybe
I have the phone and I have the app in my phone. Maybe I can play it there. Maybe I can share it through my phone. But it would take me a while to download Zoom on my phone. Okay, actually, I'm just gonna. Okay. I'm so sorry for the delay.
They would not get it. It would be first time. Yeah. It's the second notes.
Okay. I'll be able to share it on my phone. Can anyone give me the meeting number or session?
Yeah, it
Okay.
is. Can you hear me?
Yes.
It is the meeting ID is 778
17. Yeah.
88 75
75.
1141.
1141. Oh, it said invalid. Can you say that again? 7788.
7788 875
875
1141.
11. And the password, please.
Password is 097
097
561.
561. Thank you, Dr. Mylene.
You're welcome.
All right, so.
Recording in progress.
Hello.
Hello.
Yes, so I can show you guys. Oh, that's me. Okay. So this is the phone. So here I have the other app. I was also deciding on this one. So I made it like darker in color because if someone's having a fibro attack, like they would feel relaxed and not bothered by the heavy lighting. So this is it as well. So it's just the introduction. It will never appear again once you have the app downloaded. So here I'm trying to, I think this one needs a bit more coding and permission on my behalf. So this one needs a camera that would I don't know if you guys have seen like the application that allows like BP logging. It's not that accurate, but maybe pulse rate logging through just like the top of a finger, almost like you need to have like hold your camera, and to that I need to like there needs like a permission to be done on the computer wise. So until I figure that one out, so I'm trying to see if that one will work and how accurate it's going to work, and so I'm still checking that out. And it's almost the same thing with the spoon, but it's less dramatic and less I would say like gamified. The theme, as you guys can see, it's more dark mode and more almost like serious. I don't know. I'm happy to hear your criticisms. So here it's almost the same concept, as well as the same thing with the mapping and the tracking of the symptoms. You also have here like an automatic, like almost like so if you're having like a flare or like a fibro flare or like a fibro fog, like when you're having it, like afterwards, maybe you can like have like an assessment which is based on an actual like clinical it's a clinical track. I forgot what it was exactly called, but it's based on that, in which like you can also log it in so that your doctor can also track how bad, and like together you can almost like what do you call it, predict a flare before it even happens. So maybe we can try to alleviate the symptom in that way. So here it is, and it's almost like just as I said, like it is a roller so that it's simply easier and less resistance. Here as well, it's almost the same concept as the initial app, but less gamified. And you have a toolkit here when you're having an attack, in which like you can just press on this and then like almost like follow the breathing. And for people with fibromyalgia, it's more like, has a lot to do with the mind as well. So almost like a meditative state in which when we've gathered, when looking throughout our analysis during the research or slash the abstract, we noticed that most of these apps were isolated apps, in which like one was about meditation, one was about migraine. So maybe like adding it into one app would actually be helpful for these people. So as you guys can see, it's more like just a simple one. I guess this is, as I said, it's like just a beta, and we'll see like how much we can improve this application more and make it free for those who are unable to afford. And so yeah, and it also has like an AI integrated, in which, as I said, predicts the next flare. So here you'll have your month mapped out for the patient or whoever's using. And yeah, this is an extra thing in which like you just write your medication, or like whether you would like to journal, you can just write that down as well. And this is a summary, as I mentioned, like in which you can have the summary for your next doctor appointment, or it will direct it directly to your email. And yeah, and this one is just an Excel form. So yeah, and also this is just the data as to where the data, as you know, like HIPAA is like a very big thing in the US. So it's very important that we take notes. I still need to do reverse coding to also see like the security of the application, because like, the last thing that we need is it getting hacked. So yeah, that's it. I'm open for criticisms and like advice, and like if anyone would like to work on this project with me, so yeah.
Thank you so much, Dr. And this is excellent. I think you are going in the right direction. And if anyone of you interested in helping, and as Dr. mentioned in the presentation before, you can divide the project into small tasks. So every one of you can handle one thing. Let's say you are interested, but you don't have time, or you don't know coding. So what you can do is you can contact Dr. Jane and say, I'm interested. And one of the things that any one of you can do is testing. So let's say Luden completed the app, and then at one point we will need some people to test the app. Or maybe after it's done and tested, we need more people to give us feedback. So you need not necessarily the physician aspect, but you want the user aspect. So you want to test it with your family, with your friends. So you can do that as a team member when you contact Dr. Luton. So it's gonna be like sharing the link and see how they use the app in the mobile device. Is it Samsung? Is it iPhone? Is it iPad? Something like a desktop. So you will give a feedback or some if there is any bugs or any problems, then you can catch it. Catch
Yeah.
that.
Yeah, so
Yes. Thank you.
initially I targeted Android apps because like on what we found was that there was a disparity and a big gap between Apple applications versus in comparison to Google Play apps, which was Google Play was even buggy and there was complaints about like the app just not being functional and too slow. So yeah, this is why we had targeted Android. So, but either ways, we can expand into Apple as well. So, as I mentioned, like if anyone is interested in like, giving any comments, any feedbacks, or like any ideas as to how, like, I guess just don't be scared of like the coding part of it. I guess we'll figure it out together. So yeah.
One thing I found and I try to play with is down the road, this might be a feature for version 2 or 3, is adding a connection to a weather app. So you will have the weather inside your app to indicate what's going to happen tomorrow or what's the day. But because some of the symptoms in either patient is fibromyalgia or sometimes even arthritis, when the weather is wet or rainy, they will have some episode of pain and attacks and so on. So if you want, you can add that as a feature down the road. You don't have to add it now. And there are some apps that are free to connect. Thank you.
Yes, I have added that, but unfortunately, I cannot get it to sync into the actual device. So yeah, so
That's
now, I
fine.
just took it off. Yeah.
Yeah. Just
Yeah, it's a
check
trial
it.
and error. So yeah, I'm happy like if people are willing to work with me and work this out. I guess maybe just a slight headache on like syncing it with the actual application and the trial and error. But I hope like people don't get discouraged. I'm trying to also discuss with my group mates, but I feel like they are overwhelmed or maybe scared to, dabble on the coding stuff, coding parts of things. But like to begin with, I only had basic HTML skills, but it really gets easier. Like you get a gist of it. So yeah, I encourage my colleagues to also feel the same about it.
Yeah, my point is some of the people or fellows in this program or in your group or even your friends from medical school, they are not familiar with coding. It's just a very big step. So we don't want them to get into that if they are not familiar or they're not interested or want to take that step. But we can ask them to join the team where you can ask them to test, share, give feedback, and maybe comment on what color, whatever. If they have patients with, in this case, fibromyalgia, they can ask them to test the app and see what the feedback from actual patients with this condition, something like that, instead of joining the actual coding part, the technical
Okay.
aspect. If,
Okay.
if,
Thank
if
you.
that makes sense, yeah.
Yeah. Thank you. Makes a lot of sense. I wanted to ask, how about on iOS? I personally don't have. It's not as easy to
I'm
dabble
working,
on the Apple. Yeah.
yeah, I'm working on developing. It's similar. It's a curve where you learn the stuff, but the process itself, uh, I think it's parallel to the coding.
Okay. Okay.
So the AI will help pinpoint where the problems or the differences and how to solve it. So I'm working on that as well. So I complete most of my whatever I wanted to do. So it's doable, and the AI will help you figure it out. There are DeepSeek and Flame and other AI that will help get this done faster.
I've noticed that Apple, for like, I tried to actually also try to open the same files on Apple, and I noticed that they need a secondary application. Um, is is there a particular way that we can actually get it, or does it need an actual like it? You need to get
There
it
is an
approved from the Apple Store
Xcode.
first.
There is an Xcode. It's the programming app, or like Excel. It work with spreadsheet. Xcode
Yeah.
will work on the whatever code that you're working on, but on the Apple side. So
Ah, do you mean Expo Go?
no,
It's an
Xcode.
application. Oh, another thing.
Xcode.
Xcode. Okay, okay.
Mhm.
I'll write that down. Thank you so much. Xcode.
You're welcome. Mhm.
Okay, thank
So
you.
you need a device with Apple, like a Mac Pro, Apple Macintosh, whatever device that you can download the Xcode,
Oh,
and then you can work on it
okay.
there. It's similar to, I think it has also, you can download it in
Okay, okay. Thank you so much. Didn't know that.
Windows. Yeah, thank you.
Okay, okay. Thank you so much. I'll figure that one out. Thank you so much, Dr. Nadir.
You're
Yeah,
welcome. Thank you.
I also wanted to ask about how about my other team members? I know, we all had the same project of app develop, like there was one for COPD, there was one for BP. I hope to collaborate with them on the app development. I know that they're also working on the abstract, and or if there are any questions, because we've done our part on the abstract, and hopefully we can find someone to present it. So yeah, I wanted to also see what they're doing and what their plans are, so we can just brainstorm as to how we're gonna tackle if any of the
You
members.
can, yeah, you can invite or ask in the big group, see who is working on what. If you are specifically asking about the blood pressure app or whatever, there are some leaders, so you can try to reach out and see how far and what else you can
Okay.
join help. As far as course here in Michigan, uh, I can send you the list of fellows in management. Some of them already match and start its residency, so might not be available. Some might be busy with the free, but some might be available. So I'm going to just send you the whole list, and then you can contact
Okay,
them.
thank you so much. Thank you, doctor.
You're
Thank you.
welcome.
This is
Okay,
good news.
thanks.
Thank you.
Excellent. Thank you so much for sharing and keeping us updated. Anything else? Any questions, ideas, update about your projects or your what you are doing or planning to do?
السلام عليكم دكتور نادر.
Hello, Dr. Wala.
Yes,
Go ahead.
I want to ask you regarding the update of the app. You sent recently an email regarding this app. I really interested to do that, but I don't know there is any of still a dentist with me in the group, and we can start because I can see the confirmation from 2 or 3, but I'm not sure
Yes.
they start to do anything from now. If not, I'm gonna really want to start, but I need your guide to show me or to let me know from where should I get started, because I tried, I think, before once with that the 2 dentists or 3, they start to working on the previous one. But if I want to go to start the new update, from where should I start? And you can just guide me.
So I'm gonna send you what I did. So basically, I copied the old one. I had a version of that, and I used AI to uh, make it again, recreate it from the start. So I'm gonna send you that beta version. Then you can lead
Okay.
your team. You can discuss with them to group and see if there is any modification, any additions, subtraction, whatever you want to improve that. When you reach a point where you say, we all said, I think this will, you don't have to make it 100%, but at least something that we can submit, and then later on we can improve in next version and so on. So I'm gonna share you, and then you let us know what you similar to what Dr. Ibrahim is doing now.
Okay. Okay. Sounds good. Thank you so much.
Thank you, Dr. Rola. So I'll send it to update session. Great. Any other questions or any other updates, comments? Any one of you not involved in a research project or mobile application or wants to? If not, any new ideas for the program itself, the fellowship, anything you want us to change, add, improve on?
Maybe we can all work together to fix the web page a bit. Just like a little bit, like yeah, we can all work together to help Dr. Nader on the web page. As I see some fellows like they would ask in the group like, how is this? What is this? And like yeah, just maybe we can work on that together. So if any other fellows have suggestions.
Sounds good. I think that's a good idea.
Also, Dr. Nader, I think the registration for the Cleveland thing, I think it was over in May 22, or when is the last day?
No, they can accept. I called them after, and they used to have a group discount, but they said not anymore. But at least anyone can register.
And this could be counted as a CME, right?
Yes, but
Okay.
I don't think the business grammar is not going to help at this time much. The CMA itself, the certificate, but the contribution of adding it in your CV that you attended this conference and the material that in that it will help, because most of the programs like in internal medicine they want you to pass the board exam from first attempt, and this course will help.
Okay, okay. Thank you so much.
You're welcome. And it will help also with patient with fellows interested in family medicine. So there is some interlab section between family medicine and medicine, most of the common conditions that will be discussed. Thank you. Okay, if there is no more questions, I'd like to thank you all for attending this meeting. Thank you all the presenters for moderating this meeting, and you did a great job. Thank you. Thank you everyone for participation, and I'd like to thank those who will come in the future to watch these meetings. Thank you in advance, and if you have questions, let me know, and you can email WhatsApp or text or call, and we'll be happy to help you guys. I wish you all the best. Please go ahead if you have any comments. So, wonderful day. Thank you.
Thank you so much, Dr. Nadir.
Thank you and happy Eid. Goodbye.
Assalamu alaikum. Goodbye. Fi amantillah. Eid Mubarak.
Thank you. Eid Mubarak, Dr. Nadir.
Thank you, Dr. Fatima.
Thank you, Dr.
Bye-bye.
Nader.